becomes important when we talk about the brain because it's enclosed in a really non-expandable skull. And since the brain parenchyma is nearly incompressible, usually the first thing to sort of get affected is CSF. CSF gets reabsorbed through the venous system. And shortly, or rather concomitantly with the compression of that compartment comes the compression of the venous low resistance, system. And as volume accumulates, the arterial compartment becomes compromised, which obviously leads to oligemia, and perhaps if it continues, infarction. And really the sort of the last compartment to be affected, which at that point becomes life-threatening very quickly, is brain that starts to basically move and shift, whether it's to the other side of the brain through the incisura at the level of the tentorium, or down into the spinal canal at the level of the foramen magnum. So this is sort of what I've been discussing. You can see that the parenchyma makes up about 60–65% of the volume. CSF takes up 10%, and then venous blood is about 7%, where the arterial blood about 3%. So we get to a point in the brain when we start accumulating volume where the brain can do that over a large range, just like I said, because of the compliance which is given by CSF and venous blood. But at some point, the brain cannot no longer accommodate that increase in the volume, and pressure then starts to rise after that inflection point is reached. Some parameters that are of importance, especially in a critical care setting, and that regulate cerebral blood flow, are the PaO2 and the PaCO2. So PaO2, as you know, as it actually decreases, we have an increase in cerebral blood flow to sort of, and that's part of the cerebral autoregulation that happens when there's less cerebral perfusion and oxygen getting to the brain, so the vessels dilate, and that results in increased cerebral blood flow. What's really important for us, and that has a very direct clinical impact, is more the CO2. CO2 accumulation will actually cause a vasodilation phenomenon as well in the brain due to the decreased pH in the CSF fluid, and that has, like I said, this vasodilatory response, which will increase again cerebral blood flow and can lead to increase in ICP because of the increase in the compartment in the venous compartment. Cerebral autoregulation in a healthy brain is usually, so what does that mean? It means that over a long, or over a pretty wide range of blood pressures, you have, the brain can accommodate and adapt to keep the cerebral blood flow rather constant. And once we get to, once we reach levels that are, blood pressure levels that are rather high, we're talking about MAPs of above 150, then the blood-brain barrier sort of integrity becomes compromised. Those tight junctions can no longer, hold the hydrostatic pressure, and we have then cerebral edema that ensues. On the other end of that range, when we actually lower the MAP to less than about 50 millimeter of mercury, what happens is that the vessels can no longer vasodilate in a compensatory fashion. They lose their tone, and basically they basically collapse, and we have critical ischemia that happens. So this autoregulation at the level of the capacitance vessels, the precapillaries, is really what regulates the cerebral blood flow over the range now of blood pressures. Now, in an injured brain, especially in the part of the brain that's injured, we lose that autoregulation capability, and the cerebral blood flow becomes sort of linearly correlated with blood pressures. And this becomes very problematic because the brain becomes very vulnerable to fluctuations in blood pressures. So I'm going to skip over this. ICPs can be measured directly, and there are different ways, and I'll talk about those various ways of monitoring the intracranial pressure. But in the end, whether we use a ventriculostomy or a monitor, a bolt, we obtain a waveform that is of importance to us because, well, first of all, it tells us whether or not our system is actually working, our device is working. Are we getting a waveform? And the second thing is we can also look at the actual waveform and get a sense of how compliant the system is. So we classically, and this is a picture that I took from a patient that was sort of like textbook beautifully delineated ICP here in purple. We have usually three sort of pertinent waves. We have the P1, which is a percussion wave corresponding to the arterial upstroke. P2 is a tidal wave that is related to cerebral compliance. And finally, the dichrotic notch, or P3, is related to aortic valve closure. And in a compliant system that hasn't reached yet that inflection point, the P1 is usually higher than the P2. And when we're at the bedside and we're looking at the ICP waveform and we see that the P2 is higher than the P1, it gives you the sense that even if we have normal ICPs, the system is now very compliant. That becomes really important when we're challenging a ventriculostomy and raising it to see if the brain will be able to sort of take over the function of absorbing the CSF, because when the ICPs are still normal but your waveform is non-compliant, that sort of tells you that you might run into issues with challenging that ventriculostomy. Now, when you take those waveforms and you compress them over time, you can actually see, especially in pathological states, that the ICPs can, for a long period of time, be very elevated before they actually go back to more normal values. We call them Lundberg waves, and it's not something that you can actually see on your monitor at the bedside, the monitors that we have, because, like I said, it needs to be compressed over time in order to get those graphics. But the Lundberg A waves basically are very high in amplitude. They can go up to 100 millimeters of mercury, and they're usually, and as a matter of fact, they're always pathological. They usually mean that herniation is about to happen. The Lundberg B waves are of lower amplitude. They can reach up to 50 millimeters of mercury, and they usually oscillate with a frequency of 0.5 to 2 per minute. They're usually also pathological, and they indicate that you've reached the limit of your compliance. The Lundberg C waves, however, are of much lower amplitude, and they usually sort of cycle with the cardiac and respiratory cycles. So they can oscillate pretty rapidly, and they're usually thought to be physiologic. So like I said, there are different ways of monitoring the ICP. The direct ways are here on the top left, which is represented here by the EVD, or the ventriculostomy, external ventricular drain, or putting a bolt. So that goes obviously into the ventricles and has the ability to not only monitor ICPs in a more global sense, give you like a more global assessment of the entire brain's ICP, even though we know that ICPs are very compartmentalized throughout the brain depending on the pathological state and localized or focal lesions within the brain. But it also has the added advantage of being of enabling CSF diversion. We have the bolts, which can be put in different compartments, either subdural or intraparenchymal. We also have epidural bolts that are can also give us, obviously a waveform and ICP numbers. They're thought to be more local and can sample, the more local environment within the brain. And obviously they're not associated with the advantage that we seek when we need, CSF diversion, so that they don't drain, they simply monitor. And then we have a slew of different surrogates for ICPs. They don't measure directly ICPs, but they're part of what we refer to as our multimodality monitoring that give us sort of surrogate numbers for ICPs. And we're talking about the optic nerve sheath diameter, the TCDs are transcranial Dopplers are a method that we use often, not usually to look for ICPs, but more for velocities, blood velocities within the intracranial vessels. But we can derive a sense of what the intracranial pressure is based on a certain parameter that we measure through the TCDs. So I'm not going to go over this. This is the whole topic on its own. I'm going to delve more into the things that we actually commonly do here at Henry Ford, and what you will be exposed to in whatever setting you go. It's really the gold standard. It's the external ventricular drain, which, like I mentioned, has the advantage of diverting CSF as well. It's inserted with the tip, with the goal of inserting the tip at the foramen of Monro. So there's a Cocker point that the neurosurgeons basically aim at. They have certain measurements that they have to follow, and landmarks in order to get to the foramen of Monro. So this is a procedure that can be done obviously in the OR, but can also be done at the bedside if you follow those landmarks. And basically, you level it at the tragus, which when a patient is at a 30-degree angle corresponds to your foramen of Monro. And it acts really like a barometer. And whenever there is, so you set your EVD at a certain level, like 10 or 15 or 20 centimeter of water. And when the ICPs are elevate and rise above that level, then CSF drains into the burette that is attached to the system. So it's as simple as that. There are obviously complications with any catheter and drain, and EVDs are notorious for having complications like the infections, which are usually related to or usually increase with the number of attempts at placing the EVD, but more importantly, the duration of placement. Usually, we think that prevalence or rate of infection increases after day 5 of placement. And also, like I said, breaking the system in order to sample CSF and analyze it can also increase your risk of infection. In order to counter this risk, nowadays our catheters are impregnated with antibiotics like rifampicin, for instance, and that has actually been associated with a 7-fold risk reduction of infections. We also try to limit the duration of placement. The most common pathogens are, as listed here, are there are skin flora pathogens like staph, and whether it's aureus or epidermidis. Propionibacterium acnes is a common one. In patients with VP shunts, then obviously the intra-abdominal flora like gram-negative rods are also to be considered, and fungal infections in the immunocompromised. Infections are not the only complications of EVDs. Over drainage is one that we also commonly see. When you reduce the ICPs and you deform the ventricle so much that you're basically pulling on those bridging veins, you can cause a subdural hematoma. So we usually set our drainage between 5 and 15, sometimes up to 20, but rarely more than that. But it also depends on how much fluid there is and how much pressure there is. But we usually try to be cautious with our drainage rate. As any catheter going through matter, you can injure vessels and cause tract hemorrhages, and these have a sort of, in the literature, been quoted with a pretty wide range of risk, so from 0.7 to 41% risk. I would say the most common complication associated with EVD placement is really misplacement. So this is, for instance, an image with an EVD tract hemorrhage that resulted in an IVH. So this is blood filling the third ventricle here. So I was telling you about the different devices, the EVDs versus the bolts, and about the CSF drainage, which was an advantage of the EVD. But the bolts are associated with less bleeding and less infection. And you can also, and importantly, you can couple the ICP monitor with other monitors to enhance your multimodality monitoring, like the brain oxygen tension, microdialysis, or brain temperature as well. Now, to go into the pathophysiology, so brain water comes from 2 different sources. Can be intrinsic with basically cellular respiration, or it can be extrinsic from extravasation of serum into the blood and into the interstitial space. So we talk about diffusion, and bulk flow as 2 different mechanisms for blood to basically leave one compartment and go to the other. Diffusion is governed by osmotic gradient, and the concept of reflection coefficient for different molecules that we use in our hyperosmolar therapy becomes very relevant here. For instance, we usually use sodium chloride because it has a reflection coefficient of 1, meaning that for every particle that you add to the blood, every sodium chloride, none actually crosses the membrane in an we're talking about an intact blood-brain barrier, which means that basically you are maintaining a very strong osmotic gradient gradient and causing a strong pull of free water from the opposite compartment. But when you go to other solutes like urea, for instance, or even mannitol that we use frequently, that reflection coefficient becomes a little bit lower. So 0.9, for instance, for mannitol. The other mechanism is bulk flow, which comes from hydrostatic pressure. And this is relevant, for instance, at the level of the choroidal plexus. Those capillaries are actually fenestrated, so fluid can leave the capillaries into the brain interstitium, but then in order for that fluid to cross to the CSF space, like the ventricles, it's usually blocked by tight junctions. Those tight junctions, as you remember, are continuous bands of fusion between the cell outer membranes, and like I said, they prevent the bulk flow. We find them at the blood-brain barrier, so level, so at the parenchymal artery level, but we also find them at the epithelium of the choroid plexus. Gap junctions, however, permit actually the passage of water and solutes between cells, and we see them at the level of the ependymal lining of the ventricle. So this is basically just a picture to sort of illustrate how water leaves the capillaries. So here at the level of the interstitium, at the blood-brain barrier level, you have those really tight junctions, or those tight junctions, and water leaves or gets into has either leaves the vessels or get inside the vessels via the diffusion mechanism and specific channels like the aquaporins and the sodium-potassium ATPases. At the level of the choroid plexus, we're talking about the fenestrated capillaries, like here. And gap junctions at the ependymal level permit, like I said, this free movement of water between the brain interstitium and the CSF. And that becomes very important, those gap junctions, when a patient has obstructive hydro, for instance, because there's a rise in the pressure within the CSF compartment, and water can actually seep into the brain interstitium via those gap junctions. So there are different types of edema that we have to consider after a brain injury. Cytotoxic edema is different than vasogenic edema. Both types of edema can happen usually in the same with the same injury, but usually have different timelines. Cytotoxic edema is the one that you usually see more early on after an injury. It's due to the breakdown of the sodium-potassium ATPase pumps, and there's no net gain in brain water content. The correlate on the MRI would be the DWI. Vasogenic edema tends to happen a little bit later, a few hours, and can last for a few days. And what happens here is you lose the endothelial integrity at the blood-brain barrier level, and now you have water from the systemic circulation that basically seeps into the brain interstitium, and you basically gain water. So there's a net brain water content gain, and the correlate for this is on MRI is flare changes. This is an example, for instance, of an MCA stroke with resultant cytotoxic edema that over time, and you can see this with this decreased density in the brain. And over time, vasogenic edema also starts to form and causes more midline shift and mass effect. So cytotoxic edema and vasogenic edema. So the vasogenic edema, for instance, happens, like I said, with any type of injury to the blood-brain barrier. We see it very commonly in brain tumors, but also in abscesses and encephalitis. Usually the treatment for vasogenic edema or vasogenic edema responds very well to steroids. Cytotoxic edema doesn't as much, and hypertonics are usually more useful for this type of edema. Interstitial edema comes from blockage of the ventricular system and those hydrostatic forces that I was telling you about. And finally, the osmotic edema or ionic edema is when the brain is hyperosmolar compared to the plasma, and then there's that net movement of water from the plasma into or from the blood into the brain interstitium. And these are situations, for instance, of hyponatremia that we commonly encounter. The symptomatology of cerebral edema, you're all very familiar with that. Usually the more, the first changes are changes in level of consciousness. If you're equipped with your ophthalmoscope, you can do a fundoscopy and find some papilledema. Eye movements can be a subtle symptom or sign rather of increased ICPs. So cranial nerve 6 palsy is a sort of like a false localizing sign, and can usually, and especially when it's bilateral, can indicate an increase in ICPs. Sunsetting eyes as well with restricted vertical gaze is also an indicator. And then there's obviously, you can have any type of neurological deficit that can happen from increased ICPs. But importantly, and one that can herald an ICP crisis is the change in vitals and the Cushing reflex that we're also familiar with. So bradycardia, hypertension, and irregular respirations. Different types of herniation syndromes. I'm not going to go over them in detail, but when you have here number 3, the subfalcine, just under the falx, you can have the dreaded uncal herniation with compression of the cerebral peduncles. You can have the tonsillar herniation here, number 6, and you can have ascending or descending transitorial herniation. You can have an external herniation through a skull defect as well, which we commonly see post craniectomy. There is a correlation between the horizontal displacement of the pineal body or the pineal gland and the level of consciousness that has been well described in earlier studies, like this one from New England Journal of Medicine in 1986. So we know that, for instance, when you're when your pineal gland is displaced by 3 millimeters and more, usually that correlates with a decreased level of consciousness. The more that displacement, the deeper the depressed level of consciousness. So I've been talking about the different compartments and the Kelly-Monroe doctrine. Like I said, there are different ways in addressing ICP elevations. by addressing the different compartments that become affected with an increase in volume inside the brain. The first one being the venous compartment. So one way to actually improve ICPs is by improving venous return. And the very common and fast way and should be the first sort of tier one of your management is to position the patient appropriately. So head of the bed up to increase this the drainage, but also positioning their head in the neutral position, and avoiding compressing the jugulars, whether it's with the ET tube holder or just a head tilt. All of these can dramatically improve ICPs by just adopting those measures. You can also improve venous return by decreasing the level of agitation of a patient, or bucking the vent by basically reducing by increasing your venous return. If we also reduce the arterial blood volume by hyperventilating a patient and driving their PCO2 down. CSF drainage is also an important way, obviously, of reducing ICPs in patients who are able to, undergo that diversion. Not every ICP elevations is related to an entrapment in a ventricle or an enlargement or hydrocephalus. But in case it is, then CSF drainage becomes a very important way of reducing ICPs. And then in order to shrink the parenchymal component, we have different methods, and those different therapies don't necessarily work in every type of edema. So steroids, for instance, is very useful in tumors and meningitis, for instance, or bacterial meningitis, but it doesn't really work for other types of brain injuries. The more common ones that we use, and we use them across the board for almost every type of acute injury, are mannitol and hypertonic saline, so the osmotherapy. And I'll go into this in more detail. And then the brain autoregulation also involves the matching between demand and supply. So in a brain that requires a lot, or that has a high metabolic activity, requires obviously more blood, requires more oxygen, and that increase in activity in cerebral metabolic rate can actually elevate ICPs. So we find ways to reduce that consumption of oxygen by doing various things, such as, for instance, sedating a patient, but also we can induce a pharmacological coma, and we usually try to limit this to refractory cases. Hypothermia does work in some instances and not others, and I'll go into this in more details. Controlling shivering, controlling seizures, all of these will be important in reducing the consumption and the cerebral metabolic rate. Finally, surgery, which doesn't have to be a last tier. It can be actually the first tier of treatment, or tier 1 or 2 of treatment, depending on what it is that is causing the elevated ICP. So if we're talking about a subdural hematoma or an ICH or a brain tumor, it becomes an urgent therapy that should be considered early on. And I'll go into these in more details. Obviously, the first step in any management of brain coding is maintaining an airway and breathing and circulation. That goes without saying. And you have to establish the first tier of treatment before you even consider taking a patient to a scan. Because obviously, if you have no blood flow to the brain or no oxygenation, then you have no brain function. The tiers that I was talking to you about are delineated here. So they're tier 0 is the standard measures, the ones that basically include the repositioning of a patient or the appropriate sedation, sort of like low intensity sedation to minimize, agitation. And then we go into Tier 1, which has to do with osmotherapy and CSF drainage and hyperventilation. And then Tier 2 is a more intensive sort of hypertonic therapy where if you still have refractory ICPs after elevating your serum sodium, then you have to ramp up that treatment and go higher. So this is when it becomes a little more intensive. Then you have to use bigger guns in terms of general anesthetics in order to reduce that CMRO2, like the use of propofol, for instance. And finally, tier 3 is really reserved for the refractory ICPs. And we're talking about at that point hypothermia, penobarb, coma as well. So we sort of talked about tier 0 already. We generally in the neuro ICU do not like to place neck lines just because of the risk of complications with thrombosis, and those patients can obviously have an impeded, venous return, and their ICPs can become complicated by that. The light sedation analgesia is mostly to prevent patient agitation, which clearly can elevate ICPs very acutely. We treat pain and nausea as well. Tier 1, the hyperventilation, our goals are usually in patients who are not decompressed to drive the CO2 down to 25 to 30. But this is really when there's an impending herniation, when the patient is blowing a pupil, for instance. And we usually restrict it for 10, 20 minutes. But once we've temporized, or once we've stabilized the patient, our goal is usually a little liberalized to 30 to 35 millimeter of mercury. And once decompression is achieved, you can actually relax that goal even more. Based on our understanding of cerebral autoregulation, we do not want to drive the CO2 level less than 25 usually, because it can lead to critical vasoconstriction and ischemia. Our most popular way of treating ICPs is obviously the hyperosmolar therapy. Briefly mentioned to you mannitol and hypertonic saline, and basically it relies on the concept of osmotic pull and gradient that we already discussed. But it also provides or changes the rheological property of the blood. So it actually improves the deformability of RBCs and lowers the blood's viscosity, and it can dehydrate the cerebral endothelium and increase the vessel lumen. It's important to realize that over time, when you've used your hypertonic or hyperosmolar therapy for longer than a few hours to a day, the brain can start producing its own osmoles, and to try to counteract the hypertonic milieu, and this makes the osmotic gradient less efficient, and this is why a lot of times we actually have to ramp up our hyperosmolar therapy. And that's an important concept because it becomes very important when we're actually weaning our hyperosmolar therapy, because of the fact that, like I said, the brain has tried to adapt and produce its own osmoles, and dropping therefore the serum compartment's tonicity too fast can actually lead to a rebound edema. Just the most recent NCS guidelines, the Neurocritical Care Society guidelines that came out last year for the treatment of cerebral edema, tells us that hypertonics is a treatment, but unfortunately we still do not have a great evidence that it actually impacts long-term outcome and functional outcome. We know that it is effective in reducing ICPs, but there's still a lack of high quality data to show that there's a definite improvement in functional outcome. And I think it's more related to, like I said, the quality of the data that we have rather than the actual science behind it. Quickly, mannitol has a reflection coefficient of 0.9. It's used because it's easy to, first of all, to get and readily available, and you can actually push it as a bolus through a peripheral IV. When we do it, the recommended dose is 1 to 2 grams per kilogram in the event of an acute herniation. But you can also schedule boluses for just ICP elevations without necessarily a clinical herniation syndrome. We usually do 0.25 to 1 gram per kilo every 4 to 6 hours. And that's really sort of like a PRN treatment for elevated ICPs. We usually check serum ozone every 6 hours while we are continuously continuously using mannitol, just to avoid rises in serum ozone more than 320, which is correlated with acute kidney injury. And we also measure the osmolar gap, and we try to not go above 20. We do not give continuous infusions. In the past, mannitol was used as a continuous infusion, but the rebound edema that happens once you stop it is dramatic. And this is why we only use it as boluses right now. Side effects are obviously renal failure and hypotension, hypovolemia, which is something that you don't want to do when you've already had a compromised cerebral perfusion. And so this is why when we use high doses of mannitol, like 1 gram or 2 grams, we usually add a chaser with a bolus of fluid. Contraindicated in patients with renal failure. Hypertonic saline can come in different flavors, different concentrations, from 2 to all the way to 23.4, which is colloquially referred to as a bullet or as a salt bomb, for instance. It usually, depending on the institution, hypertonics of concentration 3% and more have to be infused through a central line. And when we want to have a real effect on ICPs, we usually aim to go up on this on the serum sodium by 10 points or more. So roughly, as mentioned here, for 70 kilo person, in order to achieve that level of about 8 to 10 milliequivalent rise, we usually either give 500 cc bolus of 3% or 60 cc's of 23.4. Continuous infusion can also be associated with rebound edema if it's stopped abruptly, but it doesn't have this dramatic effect like mannitol. So, but we always sort of go slow. The sort of go as quickly with the wean as you've actually gone up. I'm sorry, no, I shouldn't say this. The longer, I would say, the longer the patient is at a certain sodium, and you've kept them at a certain sodium, the longer your weaning process should be. We usually prefer hypertonics in patients that are already hypovolemic or those that are in renal failure. We have to be really concerned and careful about hyperchloremic metabolic acidosis. Because quickly your chloride can actually go up with in those patients, and in profound hyponatremia because of the risk of central pontine myelolysis, we usually have a slower or lower goal for increasing our sodium. Usually we limit it to 6 to 8 millimoles in 24 hours. But just so you know, CPM has almost never been reported in patients who are normonatremic at baseline. It's usually only seen in profound hyponatremia, and we're talking about sodiums in the 100 teens, maybe low 120s, and particularly in liver failure or liver transplant patients, but not in the general population. Steroids can be very helpful in specific situations. And I already told you about brain tumors and bacterial meningitis. In other brain injuries, it actually either has not been shown to have any effect or has been found to be detrimental, like for instance in TBI, where it's been associated with increased mortality. But for instance, in stroke or ICH, it actually has made no difference. We can use any type of steroid. Really, there's no one that's necessarily better than the other, and certainly different steroids have been used. But the more common one is dexamethasone, and it's been around for a very long period of time. We've used it for decades, and it's got a 1-to-1 conversion ratio PO to IV. Even though it has a long half-life, we tend to actually give it several times a day in cases of acute, ICP elevations. We talked about CSF diversion. Not going to go over this again. I'm going to skip this. Tier 2, when we've upped our sodium by about 10 points and we're still not seeing really a major effect or benefit, we go up even higher on that. We usually try to stay less than 160 of a serum sodium. And the reason for this is that above 160, first of all, you can go into more complications like seizures and profound encephalopathy for very little benefit. We also institute heavier analgesia and sedation in order to lower the metabolic rate of the brain, and this has obviously the advantage also to limit vent asynchrony. Fentanyl is preferred over morphine for sure, because morphine can actually increase, paradoxically, ICPs. But propofol is sort of the preferred method over any other anesthetic, because it can actually reduce directly. It has a more profound impact on ICPs, but technically, any anesthetic that will cause the patient to be sedated and not fighting or the vent or being agitated can lower ICPs. But propofol has an effect on CMR02, and especially when you're using it with the thought of causing a general sort of suppression of brain wave activity. This is where it's actually the most effective in lowering ICPs. And now when we're talking about refractory ICPs, so despite all the other measures that you would have instituted before, you're still achieving, you're not achieving normal ICPs, you have to consider the tier 3. And so we're talking about neuromuscular paralysis here, which obviously has the side effect of losing a neurological exam, depending on which neuromuscular blocking agent you use. It may be shorter or longer. But the reason why we use paralysis is to, first of all, really improve compliance with the vent, and also suppress any movement that could, trigger slight increases in ICPs in the brain that's already way past its compliance point or inflection point that we're thinking about, coughing or shivering or posturing. Hypothermia, even though it hasn't really been found to be beneficial in a number of brain injuries, except for anoxic brain injury, we use it really as one of the last resorts for treating refractory ICPs. We know that fever is a potent vasodilator and increases ICPs, and that's the reason why we want to make sure that a patient remains normothermic. Fever also increases the cerebral metabolic rate and therefore ICPs as well. The main issue that we have with hypothermia is its associated immune suppression that comes with it and the increased risk of infection. But very importantly and of great relevance, especially in our unit, for instance, in brain injured patients, is shivering. And shivering again increases that cerebral metabolic rate and increases ICPs, and we need to institute counter shivering measures in order to prevent further herniations. All right. One of the last also tools that we have for refractory ICPs is a pharmacological coma with barbiturate. But once you get to that point, usually, I mean, we're engaging patients and families in end of life discussions for usually, and barbiturates are extremely effective. Again, when we institute a barbiturate coma, we have, our goal is to achieve electrical activity suppression. So we titrate our therapy to an EEG, and getting to a burst suppression or even to a flat line. The problem with barbiturates is that obviously they have a long half-life. They will linger for days in the system. Penobarb has a half-life of 15 to 50 hours. Phenobarb 50 to 110. And it's associated with a slew of different complications, like obviously immune suppression, hypotension, hypokalemia. And you'll have to obviously have the patient on pressors in order to maintain their blood pressure. You lose your exams for days, and so you'll have to rely purely on ICPs and imaging in order to monitor the progress of those patients. And then sort of like the last thing I wanted to discuss is the surgical arm of ICP management, which can range. I mean, it all depends on what pathology we're talking about. If it's tumors, then obviously resection. If it's hematoma and ischemic stroke, we're talking about decompressive hemicraniectomy. So really just taking, the bone flap off in order to promote a more external herniation than an internal one. in infarcted tissue, it could be associated with also lobectomy in order to remove that dead tissue and give more room for the brain to swell. If we're talking about an entrapped ventricle, whether it's because of an obstructive a process in the posterior fossa or at the level of the third ventricle, for instance, then we're talking about placing a ventricular drain or a VP shunt, for instance. If we're in a setting where there's communicating hydrocephalus, such as, for instance, in the classic example is meningitis, then you can proceed with a lumbar drain placement in those patients. And then very rarely, and I've probably only been in two such scenarios, is the use of laparotomy. And we're talking about patients who you've really, done everything and for their ICPs and their ICPs can and you believe that the ICP elevation could be contributed to an ongoing abdominal compartment syndrome. So laparotomy can actually be life-saving in those instances. These last few slides were just sort of summarizing the treatment strategy per etiology. So for brain tumors, I've already mentioned the use of steroids, hypertonics, and resection. For ICH, hypertonics, blood pressure control in order to prevent hematoma expansion is paramount in the treatment of cerebral edema associated with it. The larger the hematoma, the larger the perihematomal edema. Early decompression and evacuation in older studies have actually not been found to be beneficial. The thought behind this was that we were probably being a little too rough with the surrounding white matter fibers and tracts as we were, as you have to retract them in order to get to the hematoma and evacuate it. Whereas more recently, we've had actually minimally invasive ways of removing the hematoma without causing significant damage to the surrounding fibers. And these are still underway, but they seem to be promising. Ischemic strokes and the classic syndrome is a malignant MCA syndrome. Usually when you do it early enough, within the first 48 to 96 hours, usually less than 48 hours is what has been found to be more beneficial. Removing the skull and allowing the brain to herniate outward through a craniectomy defect that's ample and of enough size can actually be not only life-saving but also has had a significant impact on functional outcome, as has been depicted in or demonstrated in 3 pivotal trials coming from Europe. So we had the Decimal, Destiny, and Hamlet. It seems like the effect is actually more robust in younger patients, less than 60 years of age. And then anoxic brain injury hypothermia is one of the rare, or anoxic brain injury is one of the rare indication for the actual use of hypothermia. And we usually have to use it within the first 24 hours in order to have an effect in preventing really the cascade of inflammation and edema before it really sets in. Hypertonics and decompression or decompressive hemicraniectomy have actually not been found to provide any benefit. And the thought being that there's so much of the brain that's actually affected globally that you are not really using hypertonics to shrink, or you can't really shrink a healthy compartment in order to make more room for the less healthy part of the brain. You know, it's a global injury, and therefore hypertonics tend to work less effectively. Hepatic encephalopathy is the edema is related to astrocytic swelling, and hypertonics can have an impact on ICPs, but the mainstay treatment is really ammonia lowering therapies, such as, you know, obviously the use of lactulose, rifaximin, and as we're trying to push in our institution, for instance, the early use of a renal replacement therapy as well. So I think this was the last slide, and I'm a little bit over. Thank you guys. Do you have any questions I can answer?
I have a question regarding the tier 1 PCO2 goals. If we have like a chronically compensated hypercarbic patient, for example, like long-standing emphysema, are there any changes in the PCO2 goals that you aim for, or do they remain unchanged?
No, so it's really in any of, so because essentially your autoregulation curve is shifted for those patients, lowering the CO2, not necessarily to the actual level of 30 to 35 that we usually do for patients who are not, CO2 retainers, but a higher goal can actually be also beneficial. It's really that, it's understanding that curve is shifted, and reducing it by about 10 points should actually give you a benefit. So you don't necessarily have to go all the way to the 30 or 35 that we apply for, the other patients.
Perfect. So your initial goal would be like 5 to 10, and then if more severe, you'd go down to like 10 to 15.
Exactly. That's what I would say. Yeah.
Thanks.
Of course.
Thank you very much, Dr. Ramadan.
Thank you. This is Dr. Howell, I believe. No?
That was me. That was Daniel.
Oh, hey, Daniel. Yeah, had the same voice as Dr. Howell.
Oh, yeah.
All right. Thanks, Daniel. I appreciate you guys.
Of course. Thank you. We appreciate it.
All right. Take care. Bye-bye.